Or you know what's
She don't know it yet, but we She
Well,
has
that's
last
one thing we are doing is
We just bought
we're taking a rough draft of the
Lincoln.
schedule with us to Little Rock. And so when we go to St. Vincent, we're gonna hand that to our clinical coordinator and say, here's what we've got right now, is this acceptable? And I don't wanna show you guys the schedule, and then you guys get your hopes up about something, and then we have to sit there and tell you they didn't accept the schedule, like they wanted it modified. So I'm not trying to hold it. I wish I could show you right now and say, hey, this is what we're thinking, but I don't wanna do that. But we do have the schedule already made. The schedule has been made, and there's a couple of you that already know about it that I've talked to in advance, but it's only because there's some people that are doing like all their rotations at one place. I think you're one of those people.
Really?
Well,
I don't wanna work for National Park, but that's okay. We'll see.
Well,
We talked about that this weekend, on Friday, and every day.
Anyway, I think the majority, if I remember right, Jason is the one that made the
That's okay.
schedules out with input from me, and so we're both on the same page on the schedule. So if you don't like it, it's both me and Jason. Okay, so chapter 30, therapeutic drug monitoring. You guys ever heard of therapeutic drugs before?
Yes, sir.
What a therapeutic drug is? This chapter goes way in depth talking about therapeutic drugs. It even talks about pharmacokinetics, and we're not pharmacists, I'll tell you that right off the bat. So there's gonna be some things that I briefly touch on. I'm not too concerned about you guys being experts about how drugs are eliminated from the body and half-lives and all that type of stuff. I'll cover the basics with you, what I think you need to know, but I will, there's one section, and I'll probably give it away, but there's like one section in this chapter that is one paragraph, and there's 3 test questions in that one paragraph, because that is what they ask every single time about therapeutic drugs, okay? So to get to that one paragraph, you gotta read about 4 or 5 pages of pharmacokinetics and all of this type of stuff, okay? So, I've got some definitions that break it down. They're very simplistic, but they're things that you need to know. Pretty much when I worked in the lab, the only type of drug that I ever knew that was a therapeutic drug was a vancomycin peak and a vancomycin trough. And it's because they order them all the time, okay? And we, as a tech, I always consider therapeutic drugs any test that has the word peak after it, or any test that has the word trough after it, okay? But the book presents it in a way to where anything can be a therapeutic drug as long as they have to test for it in the lab and they're worried about the toxicity levels, like digoxin. That is a therapeutic drug, but you're not gonna see a digoxin peak and a digoxin trough. You're just gonna see a digoxin ordered because they're worried about the toxicity of it in the bloodstream. Once it gets too high, they've got to cut you back on that. Okay, yep.
Does a therapeutic drug have a job other than being an antimicrobial agent?
Yeah, that's only a couple of them. There's a lot of different therapeutic. You have therapeutic drugs for seizures. Therapeutic drugs are basically drugs they are giving you. It's not an analyte that per se is in the body. It's a drug that a doctor has prescribed for you, and if it goes, and it's got to be a certain amount before it will have a good effect on you.
Like a
But
threshold?
Yeah, but if it has too much, it becomes toxic. And so there's all kinds of things. Heparin is a therapeutic drug that we test for, right? By doing the PTP, heparin, right? You gotta know, I mean, it's not that, the heparin that they're testing for is not what's in your body naturally. It's the heparin they're giving you by IV. But guess what? You can kill somebody if you give them too much heparin, okay? And if you don't give them enough heparin, they can have another stroke because they got a big clot, right? And so that's the reason it's important. All kinds of drugs. I mean, we're gonna go over them today. There's cardioactive drugs that are therapeutic drugs. I know all of you have heard of lithium that they give for bipolar and all that. That's one that we test for in the lab all the time. I think the main reason they test for that is to make sure the patient's taking it. A lot of people that when they're prescribed drugs, they may not like the side effects of them. And so the physician, he or she may think their patient the whole time has been taking this medicine when they're not taking it. So that's another reason that they test for drug levels in the body, is just to make sure that the patient is being compliant. Okay, so let's hit these, definitions first. Drug absorption, the uptake of a drug in the GI tract into the body. In other words, there's all types of conditions that can cause a drug not to be absorbed through the body. I know when I first started teaching, I would always call my mom about just things that involve nursing, and I'm like, tell me about drugs, when you give these drugs, tell me about, like, why is this important and stuff, and I remember she used to tell me that they used to give patients, especially the elderly patients, they would give them drugs all the time, you know, like an orally administered drug, and they would see that entire pill in their stool specimen. You know what I mean? In other words, it didn't get absorbed.
Right.
It had no effect on the patient because it went right through them. Didn't get absorbed, and that very pill that they took, I mean, it's gross, but it'll be in their stool specimen. That means it didn't get absorbed, right?
Mhm.
So that's one reason, you know, if you try to make common sense of it, some drugs are given as liquids. Some are given in different manners because the body can uptake it better in the GI tract than others. Remember, when we're young and healthy and all that type of stuff, things work properly. But when we start getting unhealthy for various reasons, even just the effect of aging, okay, our body doesn't absorb and doesn't do everything that it would, say, that a 30-year-old person would. Drug distribution, the circulation and diffusion of a drug into the interstitial and intracellular spaces. There's a section in this chapter that we're going to be talking about today called the volume of distribution of a drug. In other words, how does it get distributed in the body? Is it a drug that kind of stays in the liquid compartments, or does it distribute out into the lipids and the tissues, right? I don't know if you guys have ever heard, but some drugs are called hydrophobic, but they don't really like water, you know, and those are the ones that are going to get out into the tissues because they don't like staying in the bloodstream. Drug elimination, the clearance of a drug by the body by a variety of mechanisms. These can be hepatic metabolism that involve the liver, and then renal filtration. You know, the way I look at this chapter about as far as how drugs are eliminated through the body, anything you put in your body, if it's absorbed in the GI tract, it does what's called a first pass through the liver. That's how come they always tell you about any drug you take, whether it's an aspirin, whether it is something given by IV, anything like that, your liver has to metabolize it. Every drink in your entire life that you drink of alcohol, the liver has to metabolize that alcohol that goes through your body. In other words, it has to work. So you can overwork your liver if you're constantly taking medications and drugs all the time, okay? Now, there is one exception to that, I believe, and that's drugs that are given through suppository in the anal area.
Yeah,
Okay, I think those do not actually pass through the liver, but everything else, your liver has to metabolize. All right, peak drug levels, the time after administration until a drug reaches peak concentration in the body. Generally 1 hour after a dose, that is when we draw peak levels. If you're a phlebotomist working at a hospital and you're having to go draw a peak or a trough level, it is very important that, you know, when I used to work back before nurses drew blood and everything, we had a big phlebotomy team in the lab. And whenever a floor ordered, for example, a vancomycin peak, if that vancomycin peak was supposed to be drawn at 2 o'clock, that means they probably gave the vancomycin at 1 o'clock, okay? But you had better be there at 2 o'clock to draw that peak level. That's the most important thing about therapeutic drug testing is the time you draw the blood. Because if you end up going to lunch and you end up being 30 or 45 minutes late, that's really not the peak level anymore, right? Because that drug's not at its peak because it was given an hour and 45 minutes ago instead of an hour ago.
Right.
I think the rule that we used to have was that you had 15 minutes either side, okay? So if you were supposed to be there at 2 o'clock, you better be there between 1:45 and 2:15, okay? That was how much leeway they gave you. That was it. All right. Pharmacokinetics, mathematic modeling of drug concentrations in circulation. This process assists in establishing or modifying a dosage regimen. Therapeutic drug monitoring, the determination of serum drug levels in order to produce a desirable effect. Therapeutic range is the concentration range of a drug that is beneficial to the patient without being toxic. That's the main reason that you're testing for them. Again, the minimum drug concentration has to have the desired effect, and the maximum drug concentration has to have the desired effect. Probably one of the main reasons that they even do therapeutic drug testing is certain drugs have to be in a very narrow range to have effect. If they're not in that range, if they're not high enough, they don't do anything for the person, but if they get too high, they can cause that person to have a heart attack, okay? So you have to know what the level is in the body. All right, trough drug level. It's the lowest concentration of the drug obtained in the blood. Trough levels should be drawn immediately before the next dose. And see, the most important thing in my opinion, as far as a question that will be asked to you on your registry about therapeutic drugs, they'll say, when are the majority of peak levels drawn? And the answer is 1 hour after the dose is given. The other question they will ask is, when is the acceptable time to draw a trough level? And it's just before they're gonna give the next dose. In other words, they're just checking, making sure that that level's not high to give the next dose to. So trough levels are always drawn just before they're gonna give the next dose. Drug half-life is the time needed for the serum drug concentration to decrease by 1/2. We're gonna talk about how drugs are eliminated through the body today, and they have what's called a half-life of a drug. And I'll go over this again in a little bit, I've got it planned for lecture, but if I have a drug and it's at 200 milligrams per deciliter in your body, okay, and let's just say that I say the half-life of this drug is 1 hour, all right? That means if it's 4 o'clock right now, if it's 4 p.m., and it's at 200 milligrams per deciliter, that means at 5 p.m., what would you expect it to be?
100.
Okay. Now here's the only tricky part. Okay, so what would you expect it to be at 6 p.m.?
50.
That's correct. It's gonna go in half. Some people say you're empty. It's
No.
down to nothing, okay? So
But it has
basically,
each time.
the
Yeah,
greater
and
the
then it would be
concentration, the more it's gonna decrease. So if I was to ask you a test question, you kinda have to do it in your head. If you started out at 200, and I said at 4 o'clock, it's 200, at 5 o'clock it decreases by 1/2, okay? But at 6 o'clock, it's not down to 0,
No.
okay?
It's
It's half of
25.
what this
At
number
50.
is. So the
Well, that's
greater
50, so
concentration that it is in
yeah.
your bloodstream,
I'm
the
sorry.
more it's gonna drop.
27
But-
o'clock,
But even when it gets down to, let's say it gets as low as 25, an hour from that, now it's gonna be 12.5. You see what I'm saying? It takes a long time to completely get out of your body, but the first hour it is going to drop exponentially. Make sense to
Yes.
everybody? So you can kind of calculate that in your head. Okay, on page 610, where this chapter starts at. Overview on page 610. Says involves, TDM involves coordinated effort of several healthcare professionals to, accurately monitor circulating drug concentrations in serum, plasma, and whole blood. You'll skip about 4 lines. It says the main purpose of therapeutic drug monitoring are to, number 1, ensure the drug dosage is within a range that produces maximum therapeutic benefit, known as the therapeutic range. And number 2 is identify when the drug is outside the therapeutic range, which may lead to drug inefficacy or toxicity. We'll skip about 3 lines. It says, for some therapeutic drugs, there is a narrow window between therapeutic efficacy and toxicity. Therefore, careful monitoring and appropriate dosage adjustments are necessary to maintain therapeutic concentrations. Okay, skip the next paragraph. The following paragraph says therapeutic drug monitoring may also be used to identify patients who are non-compliant or to re-optimize a dosage regimen based on drug-drug interactions or a change in the patient's physiological state that has unpredictably affected circulating drug concentrations. Okay, so let's talk about, I gave you guys quite a few reasons. One of the biggest reasons, again, is patients that are non-compliant, but then there are also reasons, and it talks about this in your reading, but I just want you to understand that patients that are elderly or very, very sick patients, like if you're giving me a therapeutic drug, I'm gonna excrete it out my body at a regular rate, and they can almost get it down to a perfect science of what is the perfect level to have in my body, okay? But if I'm sick and my kidneys aren't functioning properly, okay? So I'm not excreting that drug out in my urine, that drug can actually build up to toxic levels in my body to where another person in a room right beside me, it may not be toxic to them, okay? So you gotta understand that there are certain sicknesses patients that can have that if you're a nurse up on a floor, you've got to watch those patients very carefully. Patients that are on dialysis are one of the number one patients that if you give them a drug because their kidneys aren't really working, that drug can kill them, okay? Those doctors, again, I go back to my mom, she used to tell me all the time, if you got a kidney doctor, they are calling the floor all the time, really, really watching their patients when any drug is given to them, because the body doesn't work as like another person would because the kidneys aren't clearing that drug, right? Same way with the liver, okay? If the liver metabolizes all the drugs, like we mentioned earlier, well, what if this person that has cirrhosis of the liver, okay? Well, then it's not metabolizing the drug, it's not breaking it down. So once again, that drug can become toxic in those patients. It's gonna be more apt to, all right? Another thing that'll be all in your reading, and I'll probably read it here in a minute, but a lot of drugs that you take, the first thing that they do when they're injected into your body is they link up or they combine with a carrier protein, okay? And most drugs, it's called the free fraction of the drug that actually has the desired effect. So the physician knows, okay, I'm gonna give this drug to this patient. I'm just making this up in my head, but they're saying, okay, I'm gonna give a bolus of heparin to this patient that's gonna be 1,000 milligrams, okay? But that physician knows that when you give 1,000 milligrams, it may combine with proteins and all of that, but there's only about 100 milligrams that's actually gonna be in the free fraction that has the desired effect. You see what I mean? Because a lot of it combines with proteins and does not actively work. So there's lots of different conditions that can cause one person to react to a drug differently than another one. Okay, and again, remember the point that certain drugs, they have to be in such a narrow window to work, and that's one reason that we test for it. Not all drugs that a physician orders for people that are sick have to have therapeutic drug monitoring done on, okay? I mean, if your doctor tells you to take a baby aspirin a day, they don't have to draw your blood to see if it's within the desired range, okay? All types of, there's so many different antibiotics that you can take orally and all that type of stuff. They're not gonna call you back to the lab to have your blood drawn to make sure it's within that perfect window. But there are some antibiotics, okay, that have to be given by IV. In other words, if you have an infection, a gram-negative infection that's really, really bad, okay, and they have to put you in the hospital for that, a lot of times those antibiotic drugs that they have to give by IV are the ones that fall under the therapeutic guidelines that you have to go, like for example, vancomycin. There's other ones that I'm sure Jason's went over, gentamicin, tobramycin. All of those are usually antibiotics that are usually given by IV. They're for infections that are really, really bad that regular antibiotics aren't working for, okay? And so those patients fall under the therapeutic patients that we'll have to constantly be drawing blood on to make sure that that antibiotic's working correctly. Okay, routes of administration. Right-hand column on page 610. See that blue bolded word bioavailability? Middle of that section?
Yes.
Okay, we're gonna start right at the end of that word. It says, in addition to IV, okay, so that means certain drugs are given by IV, okay? And I don't know that the book is gonna give you examples, but I'm gonna try to give you examples of drugs that are given by all these different methods. IV drugs are gonna be things like heparin. Heparin is usually only given by IV, okay? Vancomycin, that's an antibiotic that is only given by IV. I'm not gonna ask you that on the test, but I just don't want you to memorize this. I want it to kind of make sense to you, like what kind of drugs we're talking about that are given this route. It says drugs can be administered by several other routes than IV. Drugs can be injected directly into muscle tissue, which are called intramuscular. Okay, for example, morphine can be given intramuscular, just underneath the muscle. Then it goes on to mention subcutaneous. Drugs can be given just underneath the skin. Example of that is people that's given insulin. Okay, insulin is given just underneath the skin, so that would be an example of a subcutaneous drug. And then it goes on to say inhaled or absorbed through the skin. Have any of you ever heard of a nitroglycerin patch? Okay, those of you that are wanting to quit smoking or quit dipping, they also have nicotine patches that you can wear, where the drug is absorbed through the skin by the use of a patch.
Birth control.
Yep. Do they have patches for birth control? I thought it
Yes,
was.
they have a chart that's all about it, and it says not really effective.
Oh, it says not
It's not
effective?
effective.
Oh, okay. I know they have the little stick
They used to
things
make me
that
feel
they
Yeah,
crazy.
plant.
like at the certain places, they have a chart on the wall that looks like, oh, how effective is birth control. The
Okay,
package doesn't be anywhere near effective. I was like, that's stupid. Because you gotta give it to people.
okay, alright. And then some drugs, as I had mentioned earlier to you guys, are given to rectal delivery. And most of you know, if you ever get usually these patients that are throwing up constantly and they can't keep anything down, they'll try to give a drug, through a suppository form. And, that would be an example, you can give, morphine through rectal delivery. Oral administration, there's so many drugs that can be given orally. The examples I've got written down, for example, I told you heparin has to be given by IV. Well, Coumadin is usually taken orally. Lithium can also be given orally. So if you're on a blood thinner, if you're on heparin, you're probably an inpatient, okay, because they have to give that by IV. But you can take Coumadin at home. That's for people that are just they're in that group of people that could be prone to have strokes and things like that, but you can take that drug at home. And then I have added one that's not in your book, sublingually, okay, underneath the tongue. Can any of you give me an example of a drug you can take that they tell you need it really, really quick? Put it under your tongue.
I have
What's that?
Nitroglycerin.
Yep, that was the example I've got. Nitroglycerin, you can put that under
the
your
drug
tongue.
name. I have one.
I know, again, my mom used to tell me on the floor, their patients, she worked on a cardiac floor, and if they thought somebody was in the process of having a heart attack right there, they give nitroglycerin under the tongue. Okay, they say that's like the quickest way, and also you can do it, well, I'm just saying you can do a Xanax that way too. Okay, you can take a Xanax and dissolve that thing under the tongue, and instead of it taking 20 minutes to react, it should start reacting in about 3 minutes.
Right. Yeah, I have stomach cramp medication that I have to take sometimes. It's under the tongue.
I was gonna say like nausea medicine.
Yeah, what is it, Zofran?
Yeah.
Yeah, I know when I first started, when I very first, found out, I didn't really know what it was at the time, but when I realized that I was going into AFib a lot, it would just about scare me to death because it's I don't know how to explain it. It's like an impending doom. Your heart just starts, you're not getting a full beat, and so you're not getting all the oxygen you need. And some people can handle it real well, but it would scare me to death. I mean, it would literally like send me into an anxiety attack because I just thought, well, this is it, I'm fixing to die. And I had a doctor that prescribed me Xanaxes. He wasn't prescribing them he was only, he just said, when you go into AFib, because I was like, I was like endangering myself. I would get so nervous, you know, and be like,
So my
I'd
dad
be
does.
pacing, I
Freaks him
couldn't
out.
sit down, cause I just thought, you know, what do you do before you're fixing to die, right?
Right.
And, anyway, that doesn't normally happen, but he just kind of was saying, you know, I'm the type of person, now this is just me and I'm not pushing, but I don't believe in taking medications at all unless it's absolutely needed. And I'm just one of those people, I don't hardly take anything. So he had to really convince me of this, you know, because I'm like, no, I'm not taking Xanax. There's no way, no, period. I know what they can do to people.
Right.
And, but anyway, he said, no, I'm not giving it to you, you know, because you're, you know, you got issues with anxiety. It's just like, but you have got to calm down or it could get worse. And so, yeah, I would put one of those things underneath my tongue and let it dissolve, and oh my gosh, it felt good.
Well, cause it calm, you get
Is
the
it
calming
a,
effect.
Yeah.
easily disintegratable tablet?
But, yeah,
Oh, yeah.
yeah, he gave it to
Oh,
me
yeah,
in
they
that
are.
form, where, I mean, I could take one regular, but I wouldn't take, I would only take it if I went into AFib and it was really, really bad. But yeah, it was the kind of, put it on your tongue and dissolve in
Terrible tasting.
20, 30 seconds.
I hate
But
that
it would take effect really, really quick.
Makes me
Quick
blue.
dissolve tablet.
Makes you blue.
You know how they have,
Kill myself.
you guys know this, I mean, tablets come in different forms, like I
Mhm.
think they have, what's it called, extended release?
Yeah, it's like
Yeah.
Where you can
XR.
take you know, now you can take that same Xanax that was supposed to be quick acting, and now it can last you all day.
Right.
You know what I mean? That would be the extended
That's not
release form versus the kind that you want to dissolve underneath your tongue.
Immediately.
But there are some, you're right, Darren, because I did it one time. One time I tried to put one underneath my tongue and it was the kind that didn't dissolve. And so I sat there with it under my tongue, you know what I mean? For a long
Nasty.
time, and it wasn't going, wasn't working. Okay, so,
Stomach
the only
bugs are
thing there,
minty.
all that information is in your
My
book
stomach
except
bugs are
sublingually, and just, I want you to add that because I think there are certain, a lot of people who do take drugs under their tongue. All right, drug absorption on page 611. Now this, we're fixing to read about some of the stuff about how drugs are absorbed in the body and how they're distributed in the body. I'm mainly going over this for this chapter to make it make sense, but this is not one of the major important things that I would study for tips. It says for orally administered drugs, the efficiency of absorption from the GI tract is dependent on several factors, including the dissociation from its administered form, the solubility characteristics in GI fluids, how it diffuses across GI membranes, and whether it's in tablets or capsule form, how the dissolution before being absorbed, whereas lipid solutions tend to be more rapidly absorbed. Again, when you start reading over this, it's just gonna tell you about certain drugs, for example, are gonna be uptaken in the GI tract. Certain ones will be absorbed actually in the small intestine or the stomach. A lot of it depends on the pH that drug is taken up at better rates. I don't think any of you will ever have a question like this on your registry, okay? Because we're more involved with, okay, when do we draw that level? Why do we test for it and all of that? But it is good to read over this section under how these drugs are absorbed through the body. Under drug distribution, which is the next section on 611, right next to that blue bolded word that says distribution, it says the ability to leave the circulation for a drug is largely dependent on the lipid solubility of that drug. It says drugs that are highly hydrophobic can easily cross cellular membranes and partition into lipid compartments, such as adipose tissues and nerve cells. So that's when you get into the volume of distribution of certain
I
drugs.
missed
Yeah, I don't know that.
All right, free drugs versus bound drugs. Now, there is a test question on this section. I'm in the right-hand column on page 611 at the top under free versus bound drugs. Everybody with me? It says most drugs in circulation are subject to binding with serum constituents. It says although many potential bonds may be formed, most are drug protein complexes. It says an important aspect regarding drug dynamics is typically only the free or unbound fraction interacts with the site of action and results in a biological response. So it's the brief action of the drug that actually has the desired effect on the patient. Okay, drug elimination on page 612.
All the way down there. Where is that? Drug elimination.
We'll go down to, on page 612 in the right-hand column, do you see where that formula is that says like a change in concentration divided by, okay, go down about, in that paragraph just underneath that, go down about probably 8 or 9 lines, it starts and it says the graph shown in figure 30 TAC 2, everybody with me? The graph shown in figure 30 TAC 2 illustrates a large change at high drug concentrations and a smaller change at lower drug concentrations. However, the rate or the percent lost remains the same. Now, this is what I was showing you up on the board, okay? This is drug elimination through the body. So let's look at figure 30 TAC 2, and it's pretty much using the same example I drew up on the board. If the plasma concentration of a drug is 200 and the half-life is 1 hour, do you see like on that graph how in 1 hour it drops down to 100? Everybody see that? And then in 2 hours it drops down to 50. At 3 hours, it drops down to 25. That's just stating that fact that I showed you earlier.
Right.
The higher the concentration of the drug, the more of a dramatic drop there's gonna be. But when that drug starts getting to a lower concentration, it is still only going to divide in half each time. Now, there's another, figure 30 TAC 3 at the bottom. That basically is the same graph, except that's on semi-log paper that it's using, where you have a straight line and not a curved line. Okay, it's the same exact information on both of those graphs. Okay, the pharmacokinetics, I'm not worried about that. I'm not worried about that example. Page 614 in the left-hand column. Again, pharmacists are the ones that do all that, not us. And so don't spend a lot of time studying that. We do need to talk about what's called a steady state of a drug. Okay, I'm on, let's see, page 615. 615, there's not a lot on that page, but I'm gonna read all of it. It says approximately 5 to 7 doses are required sometimes before a steady state oscillation is achieved, as demonstrated in figure 30 TAC 6. So what they're saying is not all drugs are given in what's called a bolus form. Like I remember from working in the lab, heparin is usually given as a bolus. They give a large amount of heparin, okay? And they see what it does to the body, and then they start adjusting it, and they start running PTTs. Remember, the PTTs is what monitors heparin therapy. Some drugs that they give you, especially therapeutic drugs, they don't start drawing peak and trough levels until they have decided it's in what's called the steady state, okay? Because I want you to think about this. If I'm giving a patient vancomycin, and I know that there's a certain window, that level that vancomycin needs to be at, the first dose of vancomycin that I give them, it's usually gonna peak and then it's gonna be excreted, and it's gonna happen so quick that it never gets into that narrow range. You see what I mean? And so what they're saying is sometimes they have to give between, I think some books say 6 to 8. Sometimes they have to give 6 to 8 doses. In other words, they give a dose, and before all of that drug can be eliminated, they give another dose, all right? So it starts building on top of one another, and it usually takes about 6 of those doses before it gets into that what's called steady state level, all right? Now, I can't tell you which drugs they do and which drugs they don't, but I just want you, when you're asked a question at Student Bowl or on your registry that says about how many doses of a drug needs to be given before a steady state is achieved, they ask that question a lot, okay? So that's how come I'm even going over it with you, all right? When you're working in the lab, you will never ever have to know this, okay? Because what you'll be doing in the lab is they send you the tube of blood and they say, give me the vancomycin level, okay? You have no idea. I mean, if it didn't say vancomycin with a little P at the end of it, you wouldn't even know that they're wanting to know the peak level. You see what I mean? Because that machine is gonna run the vancomycin level no matter if it's a peak or a trough level.
So it's 6 to 8?
Yeah, I think it says, well, it says, in the reading, it says approximately 5 to 7 doses are required before a steady state is achieved as demonstrated. This figure's on the next page, and we'll turn over there in just a second. It says after the first oral dose, absorption and distribution occur, followed only by elimination. Before the concentration of the drug drops significantly, they're gonna give a second dose. The peak of the second dose is additive to what remained from the first dose. And then it goes on, and basically it's doing this over and over and over, and then if you'll turn to the next page, you'll basically you'll see where it's talking about the steady state is achieved. Does everybody see that graph at the top of page 616? Do you see where they're talking about the steady state is achieved? So not until the 5th through the 7th dose or around that area, that's when they're gonna start drawing blood on the patient, wanting to know peaks and trough levels, okay? Okay, under specimen collection, the first 4 lines of this is very, very important, okay? If there's only one thing you can study from this chapter, this is what you wanna study right here, okay? And it's very simple, but they ask it every year again at Student Bowl, and we do get feedback about registry questions. You're liable to see at least one of these facts that come from this. It says, accurate timing of specimen collection is the single most important factor in therapeutic drug monitoring. And all that means is that phlebotomist or that tech or that nurse draws the peak level 1 hour after the dose is given. Does that make sense to everybody? I mean, think about what's riding on that, okay? Because, you know, you can think like, well, you know, you got doctors and physicians and anesthesiologists and all that type, you know, those are upper tier people in healthcare, right? Those are the people that probably make a little more money than everybody else and everything. But if that person, I hope they're making more than that, but that phlebotomist that's making 9 to 12, or hopefully making $15 an hour, if they don't show up and draw that blood at the right time, those physicians are banking that blood was drawn at the right time, okay? Because if you don't draw it 1 hour after that dose is given, that answer is incorrect. But the physicians are going to be sitting there going, whoa, I need to give more of that drug, you know, that peak is really low. So, you know, phlebotomists have an important job, you know, I mean, you think about all the stuff we talked about drawing blood. And I'm not trying to put them on a pedestal, but you guys know how I feel about phlebotomists. I've always said they should make a lot more money than they make, okay?
Yeah.
Because it's an art to drawing blood, even though we can show you how to do it in there. Some phlebotomists, they're just really, really good at it. And they can do it where the patient never feels a thing, okay? And I wasn't one of those people. I was good, but I wasn't that kind of good, okay? And there's times where they have to, for example, if I'm sitting there telling you that this blood has to be drawn at a certain time, but what if I go up to that patient and I can't find a vein on that patient? And I have to stick them 5 times to get blood out, and I still don't get a sample, right? Remember I told you, you got a 15-minute window. Well, they're not gonna want, that physician's not gonna wanna hear the excuse, I wasn't able to draw that vancomycin peak level because your patients are hard to stick. See what I mean? They're gonna wanna know, why wasn't the blood ran? Why don't I have this test result back? And so phlebotomists are important when it comes to that, and it's really, I keep saying phlebotomists, anymore it's nurses, because nurses draw the blood. So it's real important that you draw that blood on time. That is the single most important part of therapeutic drug testing. And then you've got those 2 sentences that you need to make sure and remember. It says, in general, trough concentrations are drawn right before the next dose, and peak concentrations are drawn 1 hour after an orally administered dose. Okay, so now we're gonna get into what I think is the guts of this chapter that you'll need to know as a tech. We're gonna start talking about what are examples of therapeutic drugs that we will test for in the lab, all right? And so when you study these before your next test, I would break them down and I'd say, okay, Mr. Britt said, he talked about, heart, okay? These drugs are used, are considered therapeutic drugs that have to do with testing for the heart. The biggest one's digoxin, okay? But then there's also other kind of drugs that are given for arrhythmias and things like that. So I'm not gonna expect you to know everything that this book is telling you about each one of these drugs, okay? All I want you to be able to do is, I want you to be able to tell me digoxin goes with a patient that has congestive heart failure, okay? It's a cardiac glycoside given to people that have congestive heart failure. I want you to be able to tell me this drug, Dilantin, is given for patients who have seizures. You see what I'm saying? You don't have to know everything about it, but I at least want you to be able to match it up with disease correlations. Okay, so the cardioactive drugs, the first one we're gonna talk about is digoxin. The very first sentence under digoxin. Digoxin, now it's got another word for it, and I'm not worried about that other word. Okay, digoxin is a cardiac glycoside used in the treatment of congestive heart failure. That's the most important thing I want you to pick out of all that reading about digoxin. Now it does go on to tell you in that first paragraph that the concentration of dig for it to work is usually between 0.8 and 2 nanograms per mil. Now, this is one of those drugs that the reason that they draw dig levels is because it is such a narrow window for the concentration has to be in to have the desired effect. Because if you get greater than 2, and I think I talked to some other techs, and I think that they've changed it to 3 now, but digoxin, maybe next to glucose levels, was probably one of the most called critical results that we called in chemistry, okay? There are many, many patients taking digoxin that are in-house patients, okay? And if that digoxin level gets above 2 or 3, I'm now hearing it's 3, that's considered a critical level, and you have to call that to the floor. You can get in big time trouble if you have a digoxin level that's too high and it never got called to the floor. Because when you call that to the floor, that nurse, you gotta document who you called it to and all of that. And just trust me, when you hang up with them, guess who they're calling? They're calling the doctor, okay? So if you don't call the nurse, the doctor will eventually find out it was high, but a doctor doesn't need to find out that the dig level was 3.6 8 hours ago, okay? They will call that physician or whoever the physician is on call for that particular patient and give them that information. And then the doctors are gonna tell them they need to adjust the dig level. Okay, left-hand column, go down to the last full paragraph in the left-hand column. It starts off with the timing. So the timing for evaluation of peak digoxin concentration is crucial. It says in an average adult, plasma concentrations peak between 2 and 3 hours after an oral dose. Guess what? This is one of those drugs where the peak level goes against the 1 hour after the dose is given, okay? Digoxin is an exception to the rule. If you'll skip down a couple lines, it says, it has been established that the plasma concentration 8 to 10 hours after an orally administered dose correlates well with the tissue concentration, and specimens should be drawn within this window. So what they do is once they give the dig level, they're not gonna ask for a digoxin level until about 8 to 10 hours after that dose. This is one of the exceptions. But again, on your registry, if they say when do peak levels, when are orally administered drug peak levels drawn? 1 hour after the dose. Digoxin is an exception to the rule. Okay, quinidine. The only thing that I want you to know about quinidine is the very first sentence in the right-hand column at the top on page 17. Quinidine is a naturally occurring drug used to treat various cardiac arrhythmias. Okay, so I just want you to associate with arrhythmias. You will never have a quinidine peak or a quinidine trough, okay? It will just be a quinidine level. A lot of the things that we're fixing to start talking about, they're not really interested in peaks and troughs. They're just making sure that the drug is not so high in the blood system that it's toxic, okay? Procainamide, any of you ever heard of procainamide? Okay, this is another one. It says like quinidine, procainamide is used to treat cardiac arrhythmias. Disopyramide, this is on page 618. This is another anti-arrhythmic agent used in treatment of cardiac abnormalities. So that gives you 3 drugs that you need to be aware of that treat arrhythmias, and then 1 drug that's used for patients with congestive heart failure. That's what we're up to at this point. Okay, antibiotics. Okay, these are real important because these are some of the best examples of true peak and trough therapeutic drugs. I'm at the very last section on page 618 under antibiotics, just underneath that case study. It says aminoglycosides are a group of chemically related antibiotics used to treat gram-negative bacterial infections that are resistant to other less toxic antibiotics. It says there are many individual antibiotics within this classification, but the most frequently encountered ones in the clinical setting are gentamicin, tobramycin, amikacin, and kanamycin. Again, these are antibiotics that are given for gram-negative bacterial infections, and usually these have to be given by IV, so these will be patients that are in-house patients. And that means, guys, if you're working at a clinic, you will probably never test for these analytes, or I say these analytes for these drugs. But if you're working at a hospital, you will. Go down to the first full paragraph on page 619. First full paragraph on 619, on the left-hand column. It says, because aminoglycosides are poorly absorbed in the gastrointestinal tract, administration is generally limited to IV or intramuscular injection. Therefore, these drugs are not used in an outpatient setting. Peak concentrations are achieved 1 to 2 hours post-dose, and approximately 10% of the drug is bound to plasma proteins in circulation. All right, so if there is an IV antibiotic used to treat gram-negative bacteria, there's probably one used to treat gram-positive bacteria. Okay, so that's going to bring us to vancomycin. Skip over, I don't even know how to pronounce that.
Teicoplanin?
Yeah. Anybody heard of that one? Because I haven't. Okay, let's talk about vancomycin. Left-hand column at the very bottom of page 619. Vancomycin is a glycopeptide antibiotic effective against gram-positive cocci and bacilli infections. It says because of poor GI absorption, vanc should be administered by IV infusion as well, allowing peak concentrations to be achieved 1 hour post-dose. So if I'm studying that, I'm thinking I would kind of put those, and make sure you can distinguish gram-negative from gram-positive antibiotics, but just be thinking vancomycin, gentamicin, tobramycin, those are all drugs given to treat infections, bacterial infections in the body. Okay, anti-epileptic drugs. These are drugs that are given to prevent seizures or epilepsy, anything like that. The first one we're going to talk about is phenobarbital. Now you can read over that, but I just want you to classify phenobarbital as an anti-epileptic drug. On page 620, just underneath the case study, there's a drug called phenytoin. Now this is one, I'm not trying to make it hard on you guys, but a lot of people call, okay, it says phenytoin or Dilantin, and I need you to know both of those names. I'm doing that because you're gonna test for that drug in the hospitals a lot, and it seems like about half the people call it phenytoin and half the people call it Dilantin. This is a common therapeutic agent used in the treatment of seizure disorders. You guys have heard of that one, right? Dilantin or phenytoin. Okay, on page 620 in the right-hand column, valproic acid or Depakote is used in the treatment of petit mal seizures or what's called absent seizures as well. Carbamazepine on page 621, this is an effective treatment for various seizure disorders as well. Now, there are a lot of different ones that I have not mentioned or that I don't have highlighted in my book that are also used to treat seizure disorders. But the ones that I just mentioned are the ones that will be fair game for your test, okay? So if I didn't cover, if I'm even pronounced, gabapentin on page 621, unless you're just reading it for leisure, that won't be on your test, okay? The ones I covered. And again, guys, I'm just covering the ones from experience that I think, look, I've heard of that before. I used to test for that all the time. So that's the ones that I'm presenting. Okay, let's move all the way over to page 623 and let's talk about psychoactive drugs.
Yeah.
The first one being lithium. Lithium levels on page 623 in the left-hand column. Says this is a mood-altering drug primarily used in the treatment of bipolar disorders, recurrent depression, and aggressive or self-mutilating behavior, though it may be used as a preventative treatment for migraines and cluster headaches as well. Now again, they mainly test for lithium. I don't know if it says this in the book. I don't remember reading it. It's going to tell you in the book they mainly are testing for toxicity levels of lithium, where if it gets too high, there's not going to be peaks and troughs. But I know another reason, because I just used to hear this all the time when I worked in the lab, is a lot of times they're testing for lithium to see if the patient is truly taking it. Because a lot of patients that take lithium, for whatever reason, they end up not necessarily taking it all the time, or they quit taking their medication. And sometimes doctors need to know that, because the patient may not be being completely honest with them, okay, about whether or not they're taking the lithium. Tricyclic antidepressants. Right-hand column on page 623. Tricyclic antidepressants are a class of drug used to treat depression, insomnia, extreme apathy, and loss of libido. I used to remember that simply because when I worked in chemistry, we did urine drug screens and we did serum drug screens. And a serum drug screen would always consist of an alcohol level, acetaminophen, and salicylates. So in the serum, we would test for alcohol, aspirin, and Tylenol. But also there was, and I'll be honest, I didn't even know at the time, but also on that serum drug screen, we tested for something called tricyclic antidepressants, okay? And so that's where when I read this for the first time, I'm like, oh, okay, that's what that was we used to test for all the time, okay? Okay, that's enough of the antidepressants. Let's move on to immunosuppressive drugs.
Something's wrong.
Page 624, left-hand column, go a little over halfway down when we talk about immunosuppressive drugs. It says, transplantation medicine is a rapidly emerging discipline within clinical medicine. Clinical lab plays many important roles that determine the success of any transplantation program, and there are drugs associated with this, and the first one is going to be cyclosporin. Now this was a send-out when I worked, but we would send cyclosporin levels actually to Little Rock. Under cyclosporin, if you'll skip a sentence, it says its primary clinical use is suppression of host versus graft rejection in heterotopic transplanted organ patients. And then tacrolimus, right-hand column, it says this is an orally administered immunosuppressive drug that is about 100 times more potent than cyclosporin. So for the test, I'm just wanting you to associate tacrolimus and cyclosporin with immunosuppressive drugs, okay? You don't have to know everything about it. Okay, anti-neoplastics. Probably the best example of that is a drug called methotrexate. You guys have heard of that before, right?
Yes.
Okay. It says methotrexate is one of the few anti-neoplastic drugs in which therapeutic drug monitoring may offer some benefit to determining a therapeutic regimen. high-dose methotrexate followed by glucoverin rescue has been shown to be an effective therapy for various neoplastic conditions. Now, methotrexate can be given for a variety of things, but it's also used as a chemotherapy agent. All right, was that short and sweet enough?
Yeah.
All right, so
I used to
I hit everything that you possibly see in the test on that.
So methotrexate is definitely an anti-cancer drug?
They use methotrexate for more than